video of the complete hemodialysis series. So far we have seen the AV fistula sites where are all we can create. In this video we will see regarding pre-operational checkup. Suppose if you are planning to create a arteriovenous fistula for a CKD patient, what are all the checklist or the points you should be aware before creating it in a particular patient. First of all, you have to make sure the patient is having irreversible kidney function. That means the patient is in end-stage renal disease, CKD stage 4, 5, not in AK. That is very important because once AV fistula created, it comes with its own set of complication. Yes, it is the best vascular access for a CKD patient, but it have its own demerits. So it have to be afforded or given as an option for a patient who are having end-stage renal disease or irreversible loss of kidney function, that is CKD at the end stage of CKD 4 and 5. The exact GFR and all we will discuss during the CKD discussion video. In the pre-operative checkup, we can divide those into what are the points you should be knowing in the history, what are the points you should be knowing in the examination. We will see it under two columns. And these points have an impact on the patient outcome. First, in the history. Since the patient heart is going to pump the blood through the artery and it goes to the end structure and the blood gets drained to the vein and comes back to the heart. What is this AV fistula? This AV fistula creates an artificial connection between artery and the vein, which leads to chances of low resistance in the circulation, and there is a chance of high output cardiac failure. So history of congestive cardiac failure, you have to ask history of DCMP. In those patients, creation of AV fistula might lead to the worsening of the cardiac failure, especially if you have selected the major vessel like brachial artery and the cephalic vein. So you have to go for the peripheral structure. So this history is very important. Peripheral structure in the sense radiocephalic fistula, the distant part of the arm, so that the high output cardiac failure chances gets lowered down, and the patient and the attenders have to be explained regarding the risk of worsening of CCF. Second, you have to ask for the history of diabetes, history of any peripheral vascular disease, high risk of atherosclerosis. These three histories important because once you create the AV fistula, post fistula, there is a chance patient might develop gangrene if the patient is having any history of atherosclerotic vessels. Why diabetes? Because they are at highest risk of vasculopathy if it is for more than 5 to 10 years. So this history is important. Is it a contraindication? No, this is not a contraindication, but you have to take this point into consideration to consider the risk and benefit of AV fistula in the CKD patient. Third, any past history of central vein catheterization, not only dialysis catheter, any chemotherapy port, any history of central vein cannulation for the usage of central lines in ICU. Why? Because once the AV fistula is created, the high blood flow comes through the cephalic vein and goes through the subclavian vein and brachiocephalic SVC like this. Whenever there is a history of central vein cannulation, there is a chances this area might be having any kind of thrombus or obstruction, which might lead to development of the complication post fistula creation. So to take that point into consideration, history of central vein catheterization is very, very important. How many times the jugular veins been catheterized, or any history of any implantable device. Many a times patient might be having pacemaker. That history is also very important because this might have interference with the fistula outcome. So in summary, from in the history, you have to ask for 4 important points with respect to CCF, diabetes, any history of prior catheter, any implantation, because all these 4 will have a impact on the fistula outcome. And DCMP patient, CCO patient, there is a chance after the fistula they might deteriorate because of cardiac issue rather than the renal issue. Accordingly, the vascular access have to be decided for that CKD patient. Okay, these are all the important history in the AV fistula creation. Now coming to the examination. What are all the things you have to examine before sending the patient for AV fistula creation? First, you have to check all the pulses, whether all the peripheral pulses are palpable. Radial artery, you have to check the ulnar artery, brachial artery, and the axillary artery. Axillary, clinically, mostly we won't do. Brachial, radial, and ulnar. This pulse palpation is very, very important in both the hand, because if the pulse is feeble on a particular site, you will get to know the idea the patient might be having some kind of peripheral vascular disease. The fistula maturation might not occur properly, so this you have to ask, you have to examine. Next, blood pressure. You have to check in both the arms. If there is a difference in either of the arm with more than 20 millimeter of mercury, that means there is a chance of vascular disease. Be careful. The fistula arm, there is a risk the patient might go into complication. Third, Doppler study. This is very, very important. A common question by the DM resident or the medicine resident who are in the nephro posting. They will be asking the Doppler study for AV fistula, but what is the artery and vein size for AV fistula creation? In the Doppler, what are all the points you have to see? Wherever the vessel you want to make the fistula, for example, radial artery, brachial artery, and the respective vein, cephalic vein, you have to know the size. First is in the Doppler, they have to check the size. And wherever you want to make the fistula, suppose if it is wrist, you have to check the distance between the artery and the vein. What is the difference in millimeter? So that the length of suturing, how much dissection required can be predetermined. If the fistula is supposed to be, just a minute, just a minute. Sorry for the disturbance. Suppose, okay, one is size, you have to check the size, another one is the distance. Third important parameter, you have to ask the radiologist to look for any kind of thrombus in the outflow vein. What is the outflow vein? Outflow vein, this is nothing but the cephalic, this outflow tract. Any kind of obstruction till whatever the area they were able to see, that have to be found, seen in the Doppler. And in dilatation, you apply a tourniquet. Apply a tourniquet and look how the vein is getting dilated. That indicates the chances of maturation is more. If the dilatation is not there, that means the remodeling might not occur. Probably there might be some kind of thrombus or obstruction might be there. What is the minimum cutoff? Varied textbook gives varied values, but mostly the difference is between 2 to 2.5 mm. So radial artery minimum it have to be 2 mm, cephalic vein minimum to be 2 mm. Some textbooks says 2.5, but at least for the radiocephalic fistula, 2 mm is enough to make the radiocephalic. In the brachial side, 2.5 mm is the cutoff, both artery and the vein. And the distance, what is the cutoff? There is no cutoff for the distance. The cutoff, why we have to measure the distance? So that the length of the suture or the length of the incision can be predetermined. And suppose a patient, if you are having a bedside Doppler, better to mark it with the skin marker so that the incision can be exactly made at the particular site. The fistula making will be very easy. This is with respect to the Doppler for a AV fistula creation. You have to ask the radiologist for the size, distance, and any signs of non-compressibility or any signs of outflow tract stenosis. So in summary, in examination, you have to check all the pulses, BP of both the hands, Allen test, that is for the arterial circuit. Already there is a video which is uploaded last week for the modification of Allen's test, which is Barbeau test. You can see In that video, I will give the link in the description. Allen test for the arterial circuit of the hand, whether it is intact or not, between the radial artery and the ulnar artery. We have to do that in the examination. That I will discuss it in a separate video. Doppler have to be done. Tourniquet dilatation of the vein have to be checked. So these are all the most important points you have to do in examination before sending the patient for the fistula creation. History 5 points, examination 5 points. In the history, one point I forgot was regarding the IV cannulation in the periphery, in the upper limb. When, how long it was kept, because there is a risk of thrombosis or the vein damage with the IV cannula. But even if the history is missed, it can be picked up in the Doppler. So these are all the important things in the pre-operative assessment. I think already 10 minutes are gone. We will see in the next video. So this video will be continued. Bye bye.